Hello, this is Mark Kris from Memorial Sloan Kettering, speaking about a presentation at the recent ASCO meeting, and also what the implications of this presentation were. I'm referring to the trial that used adjuvant osimertinib in patients who with EGFR mutations with locally advanced lung cancers that were candidates for concurrent chemotherapy and radiation. In this trial, patients were randomized to receive either osimertinib or placebo after concurrent chemotherapy and radiation. And what they found was a huge improvement in progression-free survival in those that had osimertinib. I think this was an expected result. Those of you that looked at the Pacific data early on saw that the benefit in patients with EGFR mutations was small, and that they would do better given a more targeted therapy, and this trial simply proved that. To me, this trial raises another issue that I wanted to talk about today, and that is the need for comprehensive genotyping, preferably with an NGS test, at the time of diagnosis for suspected patients with lung cancer. And not just people with metastatic disease that is clinically suspected, but people with early stage disease. The truth is, when the cancer is first discovered, staging is usually not completed, and there is almost always now a potential use for a targeted therapy in patients with lung cancers of all kinds, all stages. I think that trial at ASCO this year shows the use of osimertinib in people that are getting locally advanced disease with concurrent chemotherapy and radiation. I think all of us see the need to test to look for the target and treat with the target. But there's another important aspect of this, and it's this idea of negative selection. Please note that if indeed you find a target, that would imply, and let's pick on ALK for a section, that would imply that if you find ALK, these patients should not receive routine immunotherapy. And that's clearly true in the neoadjuvant setting, where as part of the approval label here in the U.S., it says that nivolumab and chemotherapy in the neoadjuvant setting should not be administered in people with known EGFR ALK mutations. I think that it's super critical to have this negative selection, take patients likely to benefit from chemotherapy and immunotherapy, and exclude those with targets that would do much better on a targeted therapy. And we now know that these targeted therapies are useful here, definitely in the adjuvant setting, and very soon, hopefully, with trial data coming out in the neoadjuvant setting as well. So how are we going to do this? Actually, we've just not done a good job. What we need to do is the specialists that are performing the biopsies of these patients when lung cancer is suspected, it is absolutely necessary in 2024 to get adequate tissue for a complete histologic examination, sufficient tissue for the pathologist to render a pathologic diagnosis and determination of cell type, sufficient tissue for any immunohistochemistry tests that need to be done, both for diagnosis and for additional testing like PD-L1 or ALK, and lastly, for molecular testing. Sufficient tissue for every patient with suspected lung cancer. And I think it makes sense to do that now that we have neoadjuvant panels routinely available. So what it means is to stress to your colleagues, I'm speaking to the medical oncologists now, your colleagues that are called upon to do the biopsies, be it interventional radiology, be it pulmonology, be it thoracic surgery, please get enough tissue to let the pathologist do a complete molecular interrogation of the tumor, give you, the treating docs and the whole treating team, all the information available to make the best choices, both positively and negatively. We've not done a good job at this, and we need to work hard to work with our colleagues and get everyone on the same page to do this. The other thing that came out at the ASCO meeting this year was a poster by my colleague Jamie Chapt about the LEADER trial. And this is a trial to do comprehensive molecular testing at the time of diagnosis in patients that are candidates for surgery. What they found there was a very high incidence of driver mutations that need to be addressed one way or the other. But these drivers were found in tissue and not in blood. So I urge you, as you try to get all that molecular information, tissue is necessary in 2024. If you just relied on the blood test without the tissue, you would miss the driver in over 80% of cases. So blood, if it's positive, it's helpful. If it's negative, it's not. It misses 80% of the cases in a surgical setting. So that was the information from ASCO this year. So get the information, share it with the multimodality team that's going to define and decide care for these patients, and get all the information you can up front to make the best choices of therapy for these folks. And I think that is going to give these folks the best chance of cure and the best chance for living free of cancer for as long as possible.